Thank you, Sandra. So next I'm going to introduce our next two panelists, Dr. Paula Lantz and Dr. Jennifer Doliak. Dr. Lantz is the Associate Dean for Academic Affairs and Professor of Public Policy at the Gerald Ford School of Public Policy at the University of Michigan. She is an elected member of the National Academy of Medicine and the National Academy of Social Insurance, and she's also a member of the Roundtable on Population Health Improvement. Dr. Lantz is currently researching the potential for pay-for-success financing and other social impact interventions on population health. Dr. Lantz will speak first, and then she'll be followed by Dr. Doliak. Dr. Doliak is professor of economics at Texas A&M and director of the Justice Tech Lab. She is also a non-resident fellow in economic studies at the Brookings Institution. Her research focuses on the economics of crime and discrimination. So thank you, both Paula and Jennifer, for being here today, and let's first welcome Dr. Paula Lantz to the podium.
Good morning. It's always hard to follow Sandra, especially because I'm out of breath because he talks so fast. Anyway, great to be here today, and I'm going to pick up on some of the things that Sandra talked about a little bit in my own talk. Paths to population health, the imperative to stay upstream. And I don't know how to advance the slides. The green button? Thank you. All right, I'm going to start with a figure that's well known to most people in the audience. It's the famous Kindig and Stoddard conceptual model of population health, where population health is defined as health outcomes and their distribution within a population, and that is determined by patterns and determinants, social and other kinds of determinants of these health outcomes and their patterns over the life course. And then we want to think about policies and interventions that can intervene in these two ways here in the original conceptual model. And again, we all are quite familiar with many other models out there that tell us that, well, we can intervene at lots of different levels in society. Here, the social ecological model of health determinants. We can start at the individual or intrapersonal level, go up to interpersonal, organizational, community, public policy. Again, the classic upstream to downstream ways of thinking about the causes of health and health inequities and points for intervention. And then we have a little bit more complicated model, the World Health Organization conceptual framework for social determinants of health that also displays pretty clearly that we want to think about upstream structural determinants of health, sort of what Lincoln Phelan talked a long time ago about the fundamental causes of health, structure or socioeconomic structure in society, and that then moves you, go back. I can't go back. Anyway, you've seen that model. You know what it's saying, right? We've got upstream to downstream determinants. The history of population health and that term and how it's been defined is actually pretty long. It's been around for a while, and there's been a long time that people have been thinking about social causes, social determinants of health, even before my first example here of a physician in Germany who wrote a book in 1790 called The People's Misery, the Mother of Disease. The term population health, however, got more, I think, energy behind it and purchase in 2007 when the Institute for Healthcare Improvement, IHI, came out with their model of the triple aim as a way for fundamentally the United States, but other countries have used it as well. But in the United States, fundamentally trying to address that problem that we are so far out of the curve in terms of how much money the United States spends on healthcare per capita, way above any other place, but our population health indicators don't show we're getting much value for that. So how do we deal with that? And the triple aim from IHI was, well, we need to think about reducing costs of health care. We can't do that sacrificing patient care or the quality of care, and we also want to think about how to improve health of people while we're just trying to, again, solve this value problem, the reducing costs while improving or holding patient care constant. There's a lot of other terms out in the universe right now. I'll tell you that a few months ago I got a call from the editor of a textbook on preventive medicine, and he asked me if I would write a chapter in the book on population health. And my first question to him was, so what's your definition of population health? And he said, oh, well, the health of a population in a health plan. And my personal heart sort of sank. I was like, oh, all right, well, here we go. And I said, well, I'll write the chapter if you let me actually write about it from a broader perspective, and also try to unpack all these, what is population health if it's not population health management? How does it differ from public health, preventive medicine, population medicine, on, and we have now precision health. And more recently, the term precision public health has made a debut as well. So again, there's conflation of all these things, and I think even all of us in the room use these terms or understand them in somewhat different ways. And there is no definition of population health management. But I think there's a lot of conflation about what is being used in terms of population health and population health management out there. I had some of my students see if they could find out, like, how many, just in the United States, how many now programs do we have, degree programs, departments of medical schools, colleges, initiatives, in population health, population medicine, or population health management, using those terms. And they easily came up with 63. That number's growing. There are a lot more in the works, and all of them use that term population health really quite differently. I'm just going to give you a couple of examples. One, that Thomas Jefferson University College of Population Health, on their website, they say population health seeks to create conditions that promote health, prevent adverse events, and improve outcomes. And the 4 pillars of population health are chronic disease case management, healthcare quality and safety, healthcare policy regulations and incentives, and also the public health system with a two-way interaction, like the healthcare system and the public health system need to work together. One more out of many possible examples, the University of Alabama is now offering a Master's of Science degree in Population Health Sciences, defining population health as an interdisciplinary field that integrates clinical care and public health practice to prevent, reduce, and manage human disease. It involves a patient-centered approach and incorporates value-based health care system. I think that's a different definition that I might use of population health. I see some of you nodding and some of you going, well, that's how I think about it. So again, I think there's some themes across the ways in which different organizations, institutions, and researchers are using the term population health management, and it does include concepts of public health and community engagement. There's no question about that. And a lot of this is about training, education, training a workforce that's going to be better able to deliver patient care, understanding environment and social determinants of health. But there's also a huge growth in services and products that are being made available to people. I'll say more about that in a minute, but population health is growing. Population health management is growing into be big business. And my concern about that is that the focus of research, interventions, and policy is going, I think, more and more downstream. If you just Google the phrase population health management, the first things that will come up for you are a number of consulting groups and products and services that you could buy and purchase to better help manage the health of the population in your health plan. And it's a lot of use of, and it's using information technology, and that's good, and some of that's using, taking advantage of what we might learn from big data, et cetera. But it's if you see in the center of this, population health management, it's our care team. And it's very medicalized. And medicalization, so what's that? I'm standing up here and I'm saying something that I think most people in this audience realize. But again, I think that train has left the station and it's going really fast. So population health has become medicalized. Sociologists would say medicalization is a process by which non-medical social issues become viewed as medical problems or individual pathologies. The focus becomes more on sickness than health, and it gives medical and clinical experts the authority to treat those problems within the boundaries of their own training and perspective and expertise and their practice. Medicalization often does create new clinical services or drugs and business and service products. And again, it focuses resources and attention more downstream. So in the Kindig and Stoddard concept of population health, I think where population health management comes is actually over here. You already have a population, it's got a health distribution, and you want to better manage it with interventions, mostly at the individual level. So that's where I would put it on this. And so what are the problems with that? Well, first of all, when we start thinking about populations, smaller and smaller groups, including those of a health plan or those people who find their way into a healthcare system, we have the classic denominator shrinkage. We're caring about and collecting data on a smaller group of people. Again, there's the classic conflation of population health management, health and health care, health inequities with health care inequities. Everything's medicalized. Focuses downstream. I'm going to say that 3 more times in my short time here. And it ignores and is really then timid about those macro level factors, including policy, that are the things that are driving and creating these disparities and health problems in the first place. And I do worry about the last point on the slide here too a lot. When all this effort and money and attention is being focused downstream and that doesn't solve the problem, it reinforces notions that marginalized and disenfranchised subpopulations and their problems are intractable. Look at all the money we keep dumping on them and all the attention, and we're still not solving the problem. It must be their fault. So quickly, there's a couple of areas of research, and really my apologies to those of you in the room who are working on these things. But I think some of you are working on things that I'm concerned about. So there's all this attention now on screening patients for social determinants of health. This is actually a shot of someone I work with quite closely. Recently went to see her physician, and she started filling this out, and then she's like, "Oh, I'm being screened for social determinants of health." And Paul and I are writing about how we are concerned about this. So she gave me permission to show this to you. But you can, because she did fill out some of the questions. But you can see some of the things, and this is playing out in really different ways across the country. But there's so many health systems, community health centers, et cetera, right now that are screening patients for things like, do you need a job or a steady source of income? Are you worried about paying your utility bills next month? Do you feel unsafe in your home or neighborhood? And then the question is, well, what is the healthcare system going to do with that information? On the pro side, I don't have time to read all these. On the pro side, obviously, clinicians will do a better job of taking care of their patients and providing optimal care if they understand the social situations and contexts of their patients. That's important. But on the negative side, again, there's not going to be a huge intervention around that. So here again, we're medicalizing social factors that create health problems and health disparities. It detects adverse exposures and conditions that are well beyond clinical care. We all know that screening for anything without being able to do anything about it doesn't solve a problem ever. And you can even argue, it's not only ineffective, it's probably unethical on some levels. And this could, in populations we worry about, this could create a lot of unfulfilled expectations and further mistrust of the healthcare system. Also quickly, I know there's a lot of interventions going on regarding, well, let's find those super utilizers of healthcare. Let's find those people who are the top 5% of patients in terms of cost, or the top users, the people who, go to the emergency department 5 or more times a year. Let's find them and then let's intervene on them. It's a great idea. Also, here's the plug for, please, if we're going to do these kinds of interventions, we have to do high quality research to really understand the effects. We are about ready to publish a systematic review of all the published studies we could find on super utilizer interventions, and here's the sad reality. If you have a study design that's just a post-test design, always your super utilizers are going to look better when you look at them the next time, whether or not there was an intervention, because there's this thing called, I'm saying keep calm, regression to the mean. If you're selecting a group that's an outlier on any kind of distribution, the next time you look at them, they're going to look better because of that. So the studies that actually have good control groups show that there's also regression to the mean in the control group. They look better too, and in almost all cases, they look about the same as a treatment group. So there's a lot of work going on out there saying, oh, well, we screened our patients, the high utilizers, we looked at them the next year, their care went down, it's working. We don't really know. We don't really know if that improvement is just regression to the mean or there was something good about the intervention. I'm going to wrap up. Fundamentally, and we've heard this in different flavors this morning, the healthcare system cannot solve the drivers, the structural drivers of social inequality and thus health inequality. U.S. life expectancy ranks 35th, 36th. We won't quibble about that, but it's not great and it's declining. 40% of U.S. children live below or close to the poverty line, with huge racial disparities in that, as well as wealth. You know all these really sad statistics. High rates of mental health problems and suicide among sexual minority youth and adults. And I'm sorry, I just have to say that President yesterday said the big problem in the United States is that all these young men who have been perfect in their lives might be falsely accused of sexual assault. I would say the data better suggest that we have incredibly high rates of sexual assault and violence across the life course, and that is a problem. That is a true problem that we need to address. And also, public policy is not a savior. It's not, we're going to come in with policy and say that public policy is the driver of a number of these structural inequalities. And unless we get at that, things are not going to change. So population health, back to this model, I want us to define it more as physical, mental, and social health, social well-being in an entire population. And we are going to need to understand the patterns of these things over the life course and how they affect the patterns and the drivers, how they expect outcomes and distributions. And we are going to need to intervene downstream as well as upstream. And let me make one more maybe sort of corny analogy, but we keep talking about upstream and downstream. I want to layer that a little bit more. How many of you are hikers? How many like to go? So do you check out the hiking trail? There's the easy hiking trails, and there's the intermediate one, and then there's the challenging ones. I feel this move towards population health management is really grooming the downstream easy trails. It is making them prettier, it's making them wider, it's making them more accessible, and it might actually be doing some good. I'm not going to argue that. But what we really need to do is build those trails that go way upstream, go higher, go where the fundamental drivers of the problems are, and deal with those. And that's going to be much harder, much more challenging. If we don't do it, I'll go to my last thing here. As my friend Josh Sharfstein recently wrote, we may find ourselves awash in population health efforts without meaningful progress in the health of our population. Thank you.